Let us start. So we are here on the ESMO Breast 2026 update. This is done by Oncowisdom Circle. This is our 8th webinar. And we have today Dr. Ruhi. She is consultant medical oncologist from Shashwat Hospital, Rajkot, India. And we have, she will be presenting her take on what is important data from the ESMO Breast 2026. Over to you, Dr. Ruhi.
So a very good morning, good afternoon, and good evening to everyone. And thank you to Dr. Amol Akhade Sir for giving me this opportunity. I'll be presenting the ESMO Breast 2026 data. So let's start. So the Fergain trial, this is the 5-year update where the chemotherapy de-escalation strategy in HER2 positive early breast cancer was done, and there were 38% patients who were PET responders achieving a pathological complete response. The 5-year IDFS was 89.5%, and in patients who achieved PCR with no chemotherapy had a 92.4% IDFS rate at 5 years with one distant recurrence. So the conclusion of the trial was that within 5 years of follow-up, Fergain continues to demonstrate a PET-based PCR adapted strategy, which can identify a subset of HER2 positive EBC patients where we can safely omit chemotherapy. But are we ready to omit chemotherapy outside trials in PET responders? This study also saw the tumor uninformed ctDNA assay assessment to improve prediction of PCR and 5-year outcomes. And there was a 76% relative reduction in ctDNA with the clearance correlating with the PCR and 5-year IDFS. So ctDNA represents a promising tool for response assessment and treatment individualization in HER2 positive EBC setting. Coming to Fergain 2 trial, where we saw chemotherapy-free PCR-guided strategy with addition of TDM1 in HER2 positive early breast cancer, where we are attempting to replace chemotherapy with biologically optimized HER2-directed therapy plus adaptive escalation. And the primary endpoint was health-related quality of life. The PCR rate in this study was 60%, and there was a lower incidence of decline in health-related quality of life compared to patients who did not achieve pathological complete response. Pending mature efficacy outcomes, this strategy is clinically feasible in selected low-risk patients. So is PCR adapted therapy the future standard in low-risk HER2 positive disease? Coming to the next trial, which is TRAIN 4 study, which is a phase 1B study, seeing the neoadjuvant addition of tucatinib plus trastuzumab. And the primary endpoint was all-grade adverse events. And this trial was exploring the intensified HER2 blockade in further expanding in chemo-free approaches. Grade 3 or more adverse events were seen in 12 patients, and tucatinib was discontinued in 5 patients due to ALT/AST elevation. The PCR rates was comparable in the hormone receptor positive and negative subsets, and this chemo-free triple HER2 blockade regimen showed strong potential but warrants validation in larger studies. Coming to Destiny Breast 11 trial, where TDXD is rapidly moving earlier into the curative intent setting, where TDXD THP regimen was seen given in the new adjuvant setting with the primary endpoint being PCR. PCR was achieved in 67.3% patients versus 56% patients with an absolute improvement in PCR of 11% with a statistically significant and clinically meaningful improvement in PCR rate in the TDXD THP regimen with a favorable safety profile. There was also a shift of the residual cancer burden index to a lower incidence, signifying less residual disease with this TDXD THP regimen, especially in patients who did not achieve PCR as well. So they also had a lower incidence of residual cancer burden, so supporting TDXD THP regimen across all subgroups. Coming to the locally advanced metastatic breast cancer setting in the HER2 positive place, the HER2 CLIMB-02 trial, there was a longer follow-up update, and the primary endpoint was PFS, and with a longer updated follow-up of 45 months, there was a 2.1 month improvement seen in the PFS in both overall population and patients with the baseline brain mets, but it did not lead to a survival benefit. So the HER2 regimen remains the standard of care. Coming to another phase 2 SATIN trial, which addressed the question of what next after TDXT. So sacituzumab govitecan plus trastuzumab was given in these heavily pre-treated patients, and the primary endpoint was objective response rate. It was achieved in 3.7% of the patients with one confirmed partial response, but the trial unfortunately did not meet its primary endpoint and was stopped at the first stage. But the progression-free survival was 2.3 months and overall survival was median 9.2 months, with 9 patients requiring dose modifications due to the adverse events. So this trial concluded that sacituzumab govitecan plus trastuzumab in heavily pretreated patients post TDXT may be beneficial. It constitutes the first prospective data in this setting, and this study also emphasized the importance of growth factor support in with sacituzumab therapy. Coming to the hormone positive, HER2 negative early breast cancer space, pre-COOP era trial was done in premenopausal patients, addressing the unmet need of the limited activity of AI without OFS. So we require more potent SERDs to reduce the dependence on OFS related toxicities, where giredestrant was given with or without triptorelin before the patient was taken up for surgery. And Ki67 was seen to be substantially reduced with giredestrant plus triptorelin, and anastrozole plus triptorelin. So giredestrant plus LHRH was achieved the greatest anti-proliferative activity, and it was seen to be biologically active in premenopausal women, exploring whether we can reduce our dependence to OFS in this setting in the future. Coming to hormone positive advanced breast cancer stage, Capitello trial, the overall survival update was published this time, and the prior use of CDK4/6 inhibitors was seen in around 70% of the overall population in both arms. In the overall survival in the altered population of PIK3 AKT-P10 altered population, there was a numerical trend, but the analysis was underpowered and statistical significance was not reached. Also, there was dose reduction of around 20%, dose interruption of around 37%, and discontinuation of capivasertib around 10%. So capivasertib and fulvestrant provides a lasting treatment benefit with manageable safety, and the overall survival interpretation is limited by study power and post-progression treatment confounding. I thank you for your attention and your time. And thank you, Amol Sir, again for this opportunity.
So thank you, Dr. Ruhi. That was a great job to summarize the 4 days meeting in less than 10 minutes talk, and you did well. And I really thank Dr. Mutlu and Professor Dr. Williams for taking time out. It is on different time zones. I thank Dr. Niti, Dr. Prabhat, and of course, our presenter, Dr. Ruhi.